I think there's a lot of new FLT3 inhibitors that are either available or soon to be approved. So midostaurin is already approved and it should be used in combination with induction for all FLT3 mutated patients is, in my opinion. Quizartinib and gilteritinib both will probably be approved in the next few months. So if you have a patient who relapses, then you have two excellent options. Also in the frontline setting, all of these drugs are being tested. So we have the midostaurin data, but we're waiting for the frontline quizartinib, gilteritinib, crenolinib data. And it's possible that one of these may show better activity, and then we may even have a better frontline standard. So in a way, we are spoiled for choice. We have a lot of good options, but that's a much better situation than 8-10 years ago when we had no options. And now in our most recent updates, we are getting 75-80% 5-year survival rates, which is very, very exciting in FLT3 mutated patients. There's also a number of other drugs being developed in acute myeloid leukemia. The IDH inhibitors are a very good discovery, and as single agents, they're giving us 35-40% response rates in relapsed AML. Again, this is better than response rates we would get with high-dose chemotherapy cocktails and at a much less toxicity and much better tolerability level. So for sure, if we see a relapse patient, we check IDH and FLT3 because this will give us targeted options that are more potent, more effective, and much safer, and also have a better chance of getting patients to stem cell. So all in all, win-win all over. And then there are other new immune therapies that are emerging for acute myeloid leukemia. These include antibody-based therapies such as gemtuzumab, bispecific antibodies, immune checkpoints. A lot of these are showing early activity, so we're very excited about them. And then one of the most important breakthroughs at this time is a drug called Veneto Klax, which looks like it's really changing the treatment landscape of elderly AML, just like the FLT3 inhibitors have done for the FLT3 mutated AML. And we're seeing doubling and tripling of overall survival. And for the first time in elderly AML, we're looking at 45-50% long-term survival, whereas for 4 decades we were stuck at 10 and 15%. So overall, in young AML, older AML, relapsed AML, FLT3 and IDH mutated AML, there's a huge shift. With that is going to come a lot of requirement for education, and I think a lot of the community doctors are looking to CMEs, to talks, to ASH and SOHO and other meetings because now they do know there's a lot happening in AML and it's no longer stagnant like it was for the last 4 decades.
There are a number of other FLT3 inhibitors that are in clinical development, and how to distinguish between all the ones we have, the ones we will likely soon have, and the ones that are coming is difficult to discern at this point, likely due to it will be due to or based on differences in toxicity profiling and comorbidities and dosing. Now, having said that, I think the real movement has to be to improving the outcomes of these patients by combining them with other treatments. Now, of course, right now we are focusing on the addition of FLT3 inhibitors to chemotherapy since we've been using chemotherapy with curative intent for decades. However, as we understand the pathogenesis of the disease better, I think it makes sense to consider the combination of these drugs together, either different inhibitors that might be inhibiting mutations that might be co-present in a patient with AML, such as an IDH mutation, FLT3, which is not uncommon at all. And then the second would be to use other drugs that may actually help aid the response to a FLT3 inhibitor. There's preclinical data showing that BCL2 inhibition, P53 reactivation may be important in improving the efficacy of a FLT3 inhibitor. So I look forward to combination studies of FLT3 inhibitors with other drugs that will impact on the pathogenesis of acute myeloid leukemia.
We saw other agents being also used very successfully. For example, a BCL2 inhibitor, Veneto Klax, which has been shown also in relapsed and refractory patients, very promising results. And now we will see new results with, for example, Veneto Klax in first-line setting, but also in combination with consolidation therapy and induction therapy. And we have other inhibitors such as IDH1 and IDH2 inhibitors showing really promising results also as single agents in relapsed refractory setting. And there we also will see trials coming up in the first-line setting, whether patients can be treated specifically according to their mutation. In addition, we have now approved also, for example, gemtuzumab, which also improves the results for patients with acute myeloid leukemia, but mostly those patients with a intermediate or good prognosis. And so still we have patients with an unfavorable disease, for example, with p53 mutations or patients with a complex karyotype. There we still really not have, let's say, new agents which completely change the field.